Okay, and last but not least, it is definitely a pleasure to introduce Dr. Mike Vesia, who's a colleague over in the School of Kinesiology. And so you've heard a lot about cognition, about mechanisms. One of the things that we often see in aging dementia relates to motor functioning. And so this is relevant not just for normal aging and some of the motor related changes that we see, but also if we think about conditions like stroke, where there's often motor deficits, and then things like Lewy body or Parkinson's disease that do have a lot of motor related symptoms. So this is where, getting to know Mike a bit over the past few years, and he's really actively helping us get our TMS set up to snuff. And so this is, I think, a good chance to hear about some of the really exquisite motor physiology work that Mike is doing. So with that, I will hand it over.
Thank you, Ben. This will be a challenge. I'm Italian, so I move my hands a lot when I speak. So keeping the mic will be interesting. I also study motor control because I'm not good at it, so that'll have another factor to it. Thanks for the invitation. I'm more of I guess you can say, a motor researcher. And being in Michigan, I just want to say that has nothing to do with cars, but has to do with how we move. And so as we've already learned today, cognition and motor behavior, and in particular skilled motor behavior, is associated with learning and memory, and it depends on neuroplasticity and large-scale interactions between interconnected brain areas. So some of the principles that I'm going to be talking about today, have to do with this notion of neuroplasticity, as some of the speakers have already spoken about, but in particular in the motor system, we're talking about experience or use dependency. And so what happens is if you have a skill, that behavior can change the brain. And so by definition, neuroplasticity can be thought of as changes in the extent of interconnected brain areas in order to adapt to the environment, a physiological change, and I'll show you some examples of that, and experience. Now, it's not a unidirectional arrow here, it's actually bidirectional. So we also know that the brain, if it changes, can modify our behavior. So the question then becomes, if we're looking at this from a rehabilitation perspective, or using neuromodulation as a part of the rehabilitation, is can we change these neuroplastic changes, and how can we modulate it? And so, sorry, I just have this in the way. Let me just move this out of the way. Oops, sorry. So the question then becomes, we know that injury can cause changes in this connection, or the connectivity in the brain. And so how can we measure and modulate it? So a lot of the focus non-invasively with brain stimulation. So today what I'm going to do is focus more on the motor system, like I said, but give you a brief outline of TMS as a tool. And you've seen examples of it throughout these presentations, but I'll dive a little bit more deeply into it, and how we can both measure and modulate activity using a technique like transcranial magnetic stimulation. And as you've seen, the modulation can occur with other non-invasive brain stimulation techniques. So again, measure, modulate. I'm going to just look at, when I'm talking about measurements, electrophysiology. Our lab also does neuroimaging, and you've seen examples of other neuroimaging techniques like EEG, fMRI, et cetera. But we're going to focus just on that. So when I talk about measurements, here's a brief overview of how we can measure corticospinal excitability. And I will refer to this as the motor evoked potential. You've probably heard it before, but just in case that was a little bit over your head, what we can do is we can induce a rapidly changing current in a paddle-like coil here, the TMS coil. And what it does is it induces a magnetic field with perpendicular lines of flux that can then induce a secondary current in the brain, cause some action potentials if it's placed over the motor strip, cause a muscle twitch, synaptically, and then cause this EMG response, cause a muscle twitch, which we measure with EMG, and that is the motor evoked potential. Now, what we can also do is measure functional connectivity using a multifocal TMS technique, sometimes referred to as dual site TMS. And the idea here is that we can probe the influence of one brain area over the other. In particular, we're just going to focus on the motor cortex because we have this objective MEP that we can look at. So if we deliver a pulse, we'll call it the test pulse, and that's over the motor strip. What we can do is, like I showed you before, is invoke this motor evoked potential. So we can then set it at, say, 1 millivolt. That's shown on the left side in the shaded area there. But what we can also do is we can manipulate different intensities, parameters. But long story short, if we condition a pulse from brain area, let's say parietal cortex to M1, we can then measure what the effect is on this, what the effect of the parietal stimulation, prior stimulation has on the motor output. So it can either become facilitatory or inhibitory. And so what that allows us to do is give us a readout of functional interactions between these cortical areas, okay? And so we can now start to use this as a tool to see how these areas are talking to each other, in particular to M1. So we can get either a facilitation or an inhibition. So why is that important? So if we're looking at sensory motor disorders in action, it can allow us to do several things, okay? It can allow us to, we can use it as a diagnostic tool, and from there, potentially select treatment that's based on individual physiology mechanisms, pathophysiology mechanisms. So what I'm showing you here is a patient with stroke, again, using this dual site technique. And I'm showing you on the left there, sorry, on the right, Parkinson's patients. The take-home message that I want you to take from this is that you'll see that there's altered connections. And sometimes that could also be due to not just the pathophysiology, but we can even look at the effects of a drug. So if they're on or off of medication. So again, this is going to give us some insight when we're measuring. Those are two simple ways that we can look at electrophysiology, but then the next thing is how can we modulate it? So you've seen a bunch of different ways that we can modulate it when it comes to HD TDCS and intermittent theta bursts. So thanks for giving me that background here. So what I want you to understand here is that if we use TMS in a repetitive stimulation manner, what we can do is manipulate, and I'm going to argue, some neural circuits, and that these changes can outlast the stimulation period, at least these particular techniques. So the two that I'm going to talk about are the first one, intermittent theta burst stimulation, and the second, something that we called cortical paired associative stimulation. So think of that dual site TMS technique, but this time applied repetitively. So let me just show you some quick evidence of this. Again, some of this is a bit of a review, but I think it works out well being the last speaker. So if we were to modulate using intermittent theta burst stimulation and then measure right after, so some seminal work done by John Rothwell's group, by Huang, we can see that those MEPs are increased. So the idea here is that it may produce some type of LTP-like. And a lot of times what we're doing is, because we have these objective measures, we're using this information and then applying it to other brain areas, as you saw in the previous talk. We can also use it, we can target circuits, okay? And so what we can do is, in this example here, I'm going to show you that we're stimulating the parietal cortex, and then following up with a stimulation 5 milliseconds later to the motor cortex. So we're targeting that parietal motor network, okay? And if we repeat this every 5 seconds and do about 100 pairs of it, here what the MEPs look like, okay? So the idea here is that these changes in excitability are probably spiked time-dependent plasticity-like mechanisms. So what we can then do is use TMS as a measure. So I'm showing you here MEPs with just a single pulse, but you can also measure changes in connectivity. And then the idea here is that we can modulate and measure. So we can look at some neuroplastic related changes in the brain networks that may have been caused by a disease. So this is some of the work that I'm working with Ben on here. And the idea would be, in this case, is that we would measure some electrophysiology, then apply ITBS, for example, or CPAS over the parietal motor cortex, and then look at what can change. Now, I'm just showing you electrophysiology here that have to do with EMG. Our lab's also doing neuroimaging of fMRI, et cetera. And you saw examples of EEG, et cetera. So this is just one way of doing it. But again, it's this modulate and measure. Okay, so we have this disrupted mechanisms in the brain. So in this case, I'm using this as a proxy for progression of cognitive diseases that are outside the motor system. So the idea would be that if I applied, in this case on the left panel here, ITBS, and then measured those MEPs, in white we have age-matched controls, you can see that the disease population, you don't see that plasticity that you would generally see. So again, it could be some altered cortical mechanisms of neuroplasticity like long-term potentiation. Same thing happens when we look at CPAS here, where we don't see the expected result. So again, this could give us some insight into sensory motor integration problems or other types of problems that may be occurring. What I want to shift to next is how we could possibly personalize some of these treatments. And some of the work that we've been doing in our lab is asking this question: can we boost the efficacy of RTMS as a treatment, and can that improve potentially behavioral outcomes? And there's three things that I'm going to really quickly touch upon because I don't have a lot of time, but I'd like to show you just some of the work that we've been looking at. And we basically use this three-pronged approach. We want to look at the system more as a network, and so how we can possibly target either specific networks, but use a network approach. A lot of times, I'm going to talk about state-dependent brain stimulation, but a lot of the times we're just applying this at rest. So what happens when you engage someone? And I think from the last talk, you saw some of the accelerated stimulation. So what are some of the effects of dose-dependent stimulation? So like I've kind of alluded to, most of the neuro rehab typically targets at least in the motor system. So if we're looking at stroke, they'll target the M1 motor cortex. But we know that besides local effects, there's also network-wide effects. And so what we're doing is we're looking at a parietal motor network that's involved in actions, and we'll use this network approach to change downstream motor function responses to stimulation. The other thing is that, as I've alluded to, stimulation is usually applied while participants are at rest. And so what could happen is that stimulation can go all over the place, if you will, okay, because it's ill-defined. Some of the work that's been proposed by others, but hasn't really been looked at thoroughly in an offline technique using network activation. So what happens if we control the brain state? And in this case, when I say control the brain state, I'm going to engage the person in an actual grasping task. And then, of course, based on some of the depression literature where they've done accelerated ITBS type protocols, brain stimulation protocols within that are based on space learning. What are the effects of dose within a day and across many days? So just quickly, what I'm showing you here is just some work that I've done during my, I guess it was my PhD at that point, where we can activate these networks. And the goal here is to look at what happens when we stimulate a particular node in this network and how can it propagate through the system. So I'm going to just focus on the parietal cortex. I'm just going to call it parietal cortex. There's an actual specific area, but for just to keep this simple, I'm going to look at how can we now use this dual site TMS technique to actually get some causal interactions between, in this case, the parietal cortex and M1. And by using this direct and objective insight during behavior, we can, personalize the stimulation. And so what do I mean by that? So what we have subjects do is, again, this is like that measure. So the dual site TMS, we have people plan a different type of reach to grasp. So they either just touch an object, do a precision grip, or do a whole hand grip. And if we apply that stimulation during the course of a planning phase, we could actually get pretty good at manipulating or finding out when that activity is, for example, facilitatory. Okay, so that's the goal here. So the state dependency, meaning that the behavior changes the state of the brain, and then we could look at when to stimulate. And so what I'm showing you here is just data from a previous study where we found that if you engage a person in this activity compared to rest, you get this activation. And more importantly, we can get very specific, for example, like when to stimulate during this planning phase. And so again, what this allows us to do is constrain the brain state with a motor task that increases the excitability in this parietal motor circuitry. And in this case, we can target while they're performing an action. So as I've alluded to already, the question then becomes, can we use grasping tasks during stimulation to selectively activate the brain network? So the idea here is that when you're at rest, you got a lot of variability because the brain could be just doing a lot of different things, okay? But what we're doing here is we're saying, this is how we're gonna stimulate. We're gonna activate this network, okay, that we've defined with dual site. And now we're gonna apply a modulation type technique, so an ITBS, in this case over the parietal cortex, a node in this network, and see how it would affect the specific network. So that we don't have what we call sometimes off-target effects that may not be effective when we're stimulating and cause other things to happen. So again, we're gonna target the network, stimulate the parietal cortex, and then look at how it changes things. And so by doing so, in this case with the idea here with intermittent theta burst stimulation, is that we're able to increase the stability, and I'm just going to talk about this from a network perspective, to strengthen these brain connections. And so the idea here is that maybe we can induce some synaptic LTP, and as a result, improve plasticity, so strengthen those connections. So what I'm showing you here is like, we use this mapping technique where we can then individualize this for a particular subject, okay, and see where their area in the parietal cortex has the most facilitation. Choose that technique based on while they're grasping, so not just when, but how, and then apply the stimulation for that individual based on that personalization. And so I'll just show you some data from a paper that my PhD student, Alana Goldenkopf, has just published. And so the idea here is, can we, if we engage someone in a grasp compared to rest and stimulate the parietal cortex, can we modulate downstream motor excitability? That's part of that network. And can we then improve fine motor skills? So the 9-hole pegboard test. So what we did is we had some pre-assessments, and we had 3 conditions. People would be stimulated while grasping during the ITBS that was timed, or they would be stimulated just with ITBS to parietal alone. And then we chose an area that we saw with the dual site that was not facilitatory and not part of the network. We also did some imaging that I'm not showing here to define that, and use that as a control. And then we did post-assessment. So what I'm showing you here is MEPs, so motor excitability. And what you can clearly see is that immediately after stimulation, for up to 60 minutes, we get an increase in MEPs downstream from where we stimulate. So recall, we're stimulating the parietal cortex, but we're affecting this immediate, if you want to call it plasticity or MEP change, okay? You don't see that with the other 2 control conditions. This also maps out really well with the 9-hole pegboard test. This was actually quite fascinating for us. We didn't expect this to happen, but we saw some really large improvements that were specific to this state-dependent stimulation. Then the question became, well, what happens if we add more stimulation? And so in the first experiment I just showed you, it was a pilot that we did. We did it in 24 participants. Now what I'm going to show you is what happens after 3 subsequent days of stimulation. And what we get is a similar effect, okay? So we still get that excitability. There seems to be, at 60 minutes, also something happening with parietal stimulation alone. And again, it's network targeted, so that could explain parts of it. What's really shocking here, this is the individual data here, it's very, very consistent across individuals. Behavior-wise, we get similar effects, okay, that we saw before. And again, variability very low, it's very consistent. We also, so let me just summarize here. What I showed you is that by controlling the brain state during stimulation with a grasp task, we can improve performance. This brain state dependent parietal stimulation induces immediate changes in the motor cortex. And the brain state dependent parietal stimulation can enhance the impact of the neuromodulation on motor function. I'm not showing you the data today. We tested them, and I'm moving my hands here. We tested them a week to 2 weeks after, depending on the individual. And these effects are persistent, at least in neurophysiology, not behavior. And we also have imaging data, which I'm not presenting today, that's supporting changes in this connectivity. So again, what I'm showing you here is that, yes, if we use a network-targeted stimulation approach that's personalized, and it's based on some type of state dependent that we're deriving from this dual site TMS. So by doing that measuring, okay, we can not only know where to stimulate, when to stimulate, and that can potentially help us with the how to do it. So then the next question here is that, can we repeat spaced cortical paired associated stimulation to promote plasticity in the human parietal network? So I'll go through this really quickly here for the sake of time, but this is based on some accelerated ITBS work that's been done in depression. And so this idea of what happens if we, use a 60-minute interval, for example, between a stimulation. And this is based on classical work that shows that a 60-minute interval, distributed practice can enhance motor learning. And so what we've done is we've applied stimulation with these intervals. Just to reiterate here, I'm showing you the CPAS effect. Okay, so we'd have this increase in connectivity if we use 5 milliseconds and we repeat it every 5 seconds for about 100 pairs or so. And then we have a control, a temporal control here, so we don't get the so-called Hebbian plasticity effect. Okay, and here's our design, and we have, this is a within subject design, and we have people come in and they get CPAS, and then it's quite boring. They'll sit in the chair for 50 minutes, and we'll take some measurements before and after each. And in the single dose, we give them stimulation, and then we give the same amount of stimulation on the brain, but it's not supposed to be Hebbian as a control. So what I'm showing you here in pink is the additive effect of multi-dose stimulation in this parietal motor network, so we can modulate this network. We don't see this with the control, so you can see in the post 2 and post 3, it goes down, okay? And on the right there, I'm just showing you the individual data. But then the question becomes, well, a lot of times we're going to apply this, for example, in stroke populations or any disease state, which tends to be in older adults. And what we've shown in the past is that if we do this dual site stimulation, there seems to be some age-related brain state changes in the connectivity. So here we're just measuring that in a previous study. But we did the exact same thing in older people, and here's what we found. Scales are a little different here, but we don't get an additive effect, okay? But there seems to be, and I can't explain what's happening in post 2 and 3. It could be boredom, it could be some other effects that happen after this first CPAS, but it seems to not decline at a similar rate. So just to summarize, we show that repeated multifocal stimulation has a cumulative dose-dependent effect on motor excitability in younger adults. We don't see, there's no additive effect that we saw in the older adults. And there's some type of, I would just want to call it a stabilization effect that's occurring. So long story short, what I'm trying to get at here is that you can use a lot of these principles for other types of stimulation. And I think it's important to, as you saw with a lot of the speakers, that we really consider the network. And when we are choosing our stimulation, what that does, what happens if we engage someone in a task? So the question becomes like, are you applying the stimulation before a given task and how it may have an effect, or during a task? So, maybe with some of the TDCS, by having them being engaged in a task, you may get the more desired effect. It all depends on the question. So knowing when, where, and how to do it can affect how we can use this information and translate it later on into the clinical realm. And again, I'm just talking about the motor system, but we can use these principles outside the system. Thank you. And these are all the people who do the work. Thanks.
All right, so any questions for Dr. Vesia?
if I induced a lot of pain, we have an expert that can help us here.
So one just real quick one. I know with this as a model in kind of neurologically intact individuals, I know that you've in the past done some work with stroke and with Parkinson's. Do you have any hypotheses about what we could expect or how this might change?
It's a great question. I'll start off with we don't fully know. But what's interesting is that sometimes, at least in the stroke literature, or when we've done some of this work in stroke, because some of the connections may be aberrant, and assuming they have a intact corticospinal tract, they actually can respond a lot better. And it could be because their brain is just more willing to receive or more able to change because of the plasticity. We're not seeing that with older adults. But a lot of what's happening, I think, is a dosing issue, I think. And so one of the follow-ups we want to do with that CPAS is what happens if we engage them? And so the idea here is that maybe we can get some subpopulation of neurons that are active and that we can maybe target. And so I think it's an open question. It's hard to say. Some of our preliminary work is suggesting that it's a little bit more effective actually in patients. And so I'm not sure, I guess I can ask this out to the panel, what people are finding when you're working with a disease population. Do you find that, some of the effects could either reverse or be a lot easier to induce because the system is, ceiling floor effects kind of type of thing, or just more plastic in its nature?
Yeah. Awesome. Thank you. And